So what I'd like to do is thank David and all of the foundations. There's so many foundations in the world. For an academic, this is like nirvana. But really, as a member of the committee, this has been wonderful to see all the research that all these foundations have funded. It has made our research so important in our activities today. We've just relied on all the stuff that you have in fact done. So I'm asked to present on behalf of the committee our policy recommendations. So let me just quickly get started in doing some of these. So basically what you heard about already today is there's a lot of very promising models out there. But what we also see is many of these promising models have not gone past the demonstration phase. And so what we were trying to figure out in this project is how do we go from a great demonstration to a program that's going to be sustained, that's going to work in lots of different settings. So that's essentially what our challenge is, this part of the activities. And so we thought of it, and we thought of 5 areas that we thought were very important for us to focus on. And that's what I really want to concentrate on for my 15 minutes. The first one is the whole issue of integration of social supports, which we've already heard about and are still, and we just want to elaborate a little bit more on. The whole issue of care delivery and the workforce that's behind all this activity. The issue of payment policy, which I know we're going to talk about later on today, but we wanted to talk about it in a policy context. The issue of quality measurement, and again, we're going to talk about a little bit later, and the whole issue of data infrastructure. So these are the 5 basic categories that we're focused on. What we're not focused on, because I know we're going to hear about it almost immediately, is, and I've been in a public health school for 35 years, and we are all about prevention. We are not talking today about prevention of chronic conditions. We are not talking about how to keep somebody healthier even if they already have a chronic condition. That is exceedingly important, but not our focus today. So we are not focusing on the issue of prevention. So the first thing, and we've heard about it already a number of times today, people with high medical needs also require, in many cases, a lot of social support. And we heard examples from our first panel of needing for housing and transportation and home care and nutrition and whatever, and that's embedded in our typology. We recognize that. The problem, however, and from a policy point of view, is that it's been exceedingly difficult to integrate these medical and social services, both technically, when you had the money to be able to do it, and because separate funding sources make it even more difficult. So we were trying to figure out how do we essentially try to do a much better job of integration. And basically, what we recognize is that the federal government, the state governments, and the different payers need to revise their financial incentives and their organizational systems to recognize these social risk factors. What we find is that many of these models are not financially sustainable unless they save money for the medical care system. So it's the medical care system that's in the lead, and the social services are the add-on to it, and they are essentially important only when they save money for the medical care system. Money for social services is invested primarily when it saves money for the medical care system. And so they're the second thing. The money, when there is savings, is quite often not returned back to the social service systems, which are so important to the whole system. And so basically, what we know is that social services have their own importance, their own reality, besides just saving money for the medical care system. And yet, the way most of the programs that we look out there do, it's because they can save money to the social services. And if we look at where we should look for these types of programs, it's probably not very much domestically. It's much more internationally. We spend about 8% of our total budget of the United States on social services and about 17% of our total budget on healthcare. And if we go to Europe, if we go to most other countries, it's the opposite percentages. They're getting a lot of return on their investment from investing in social services that we are not getting. So the first thing that we want to do is figure out ways to integrate these social services so that they're more important and they're standalone, and they essentially, the medical system doesn't get all of the benefits from better social services. So there's a trade-off. There's an independent need for these social services, and one of the things that we talk about in the report is the whole issue of health in all policy, which is essentially taking a look at what's going on in agriculture and food and what's going on in transportation and what's going on in parks and all those things, and how important is health in all of these kinds of activities. So we're very interested in getting the whole health system engaged in the rest of the U.S. System of care. The second area is the whole issue of care delivery and workforce. And basically, what we see is that care systems are being developed to basically better serve the high-need individuals. So we're seeing that's happening, but it needs a much greater expansion. Where we don't see as much effort as we would like to see is from the payers and from the health systems, which there are promising models. Arnie talked about the promising models. We see a whole series of promising models, and yet people are not taking those promising models and diffusing them as rapidly as we would like to see it happen. So we really want the payers and the health plans, et cetera, to really step up to the plate, take a much closer look at what we see as the promising programs and try to see how they work in their programs. Basically, the whole issue, and we talked about it earlier today, matching the high-need person to the appropriate model. How do we do that? In a technical way, we sort of know what to do. Ashish and Jose have given us the models. How do we then match them to the appropriate care model? Arnie gave us some ideas. We really need a lot more on that. And then just the whole issue of promising practice, really getting the message out there. These are the ones that you should really take a look at. It's sort of hidden. We have to look pretty hard to find them, and we really need to really emphasize those promising models. What we recognize is the training system that we have today is designed around the needs of the 20th century, not the 21st century. If you look at medical schools and what they are doing now, they are really still focused on the body part type of mentality. We essentially really know how to take care of the person's diabetes, and we spend a week in medical school talking about how to train somebody to take care of their diabetes. We don't focus often on the whole person, and we really need to do that. So that's a change in the medical curriculum. The nurses often, and the social workers, are in fact the major care coordinators that we've heard about in most of these programs. But if you look around the country for programs, if I wanted to be a care coordinator and I wanted to go to nursing school, where would I go? That's a hard challenge. They're sort of there in many programs, but you really need a much stronger curriculum around care managers. What we're finding when we talk to the programs is they do it themselves, which is fine, but given how important this is, we need much more curriculum. And then we have all these nurses, all these people that we've heard about today that are engaged in these different parts of taking care of the person. And we need to have, as part of their medical school curriculum or clinical programs or whatever, a set of programs, of educational programs to deal with this, both in training, but also for CME. Essentially, you don't see very many CME programs out there trying to deal with the whole issue of care coordination. And we've got all these people trained in sort of the 20th century medicine, and we've got to figure out a way to train them for the 21st century medicine. Basically, you need to have some support for medical education that serves the high-need population. If we look at the medical school curriculum out there, if we look at the nursing school curriculum out there, how many of them really focus on the high-need population? And we don't really see a lot of that, and so we'd like to see that much more emphasized. In clinical education programs, the whole issue of socioeconomic determinants of health gets mentioned, but doesn't get mentioned very often, and it is such an important part of taking care of the high-need, high-cost person that we think really it needs a lot more emphasis. Lots of information about promising practices. How should you be taking a look at? I talked to the medical students at Johns Hopkins, and they're very interested in the whole issue of, how do I deal with a person who has multiple needs? And what we pretty much do is send them out to a primary care physician and say, watch. And that's not a particularly effective method for doing so. So we really need to figure out what to do. The discussion of scope of practice. What is the responsibility of the doctor? What's the responsibility of the social worker? What's the responsibility of the nurse? We don't really have a good sense of these kinds of things. We need to have a much better sense of that, according to our committee. And then, especially with respect to mental health, the whole issue of stigma. What do we do about the issue in the community, in the medical profession, about the whole issue of stigma? And certainly we know that there are models that worked. Arnie gave us 16 models that work, and we should take a look at those. But essentially, those typically work in a setting, and they work probably very well in that setting. But how do we get them to work in a second or a third or 100 different settings? And that's where we haven't really spent a lot of energy in trying to figure out how do we take a good idea and diffuse it widely in those. So kinds of research that we think needs to be done is how to identify people who have high needs in actual practice settings. So we know how, Melinda explained to us the typologies. How do we make that real in a practice setting? That really hasn't been done, in our opinion, very well. The people who are going to be high need in the future. We have risk adjustment methods. We have a variety of things out there, but we really haven't those are pretty much about cost. Who is going to be expensive next year? Because we need to do that for risk adjustment in Medicare Advantage and other kinds of things. We don't have the equivalent model in most cases for identifying who's going to be of high need next year, which is similar but not the same question. And so we need a whole set of research around who's going to be the high need person next year. There's a lot of different models that you hear about on care coordination. We need to really focus on what are the best models for care coordination, and maybe they do vary depending on the needs of the population, where they are in the typology, how many problems the person has. But we don't have good research on the best methods for care coordination. How do we integrate medical and social services? What are the best models for doing that? We've got a lot of models on how to integrate medical services. In integrating medical and social services, much less modeling, much less experience. A lot of this is happening in Europe. We haven't brought a lot of those ideas from Europe to the United States. At least that's where we might want to start, because we just don't have a lot of models in the US. And then cost-effective implementation processes. In terms of payment, there's been significant improvements over the last 5 or 10 years in paying for care coordination, recognizing the importance of social supports. And we want to recognize those very important additions to the payment policy. We think that it makes sense for people with high needs and high cost to talk about value-based purchasing. Medicare now pays for care coordination. Medicare managed care and a lot of the private insurers have recognized the importance of care coordinators for people with high needs. Public agencies, the duals and everybody else have a whole series of task forces around the integration of medical and social services, and we think those are absolutely wonderful. But essentially what we see is a one-size-fits-all approach right now for care coordination in the fee-for-service sector. So you get one payment for care coordination. And that's better than no payment. But essentially, if you look at the typology, you see that certain groups need a little bit of care coordination, some need a little bit more care coordination, and some people need a lot of care coordination. And having one payment, the one-size-fits-all payment for care coordination, just really, for us, does not make a lot of sense. If you look at the risk adjustment systems that are out there, and how CMS and everybody pays for managed care, what you see is significant improvements in paying for people with multiple chronic conditions that are high needs and whatever. Significant improvements over the last 20 years. But still, if you look at that top end of people, the top 5%, they are still pretty much systematically underpaid under most of the risk adjustment systems that exist out there. Maybe it's just concern about regression towards the mean or something else, but you generally see that, and a bit of overpayment for the people that don't have as many chronic conditions or are generally healthy. And then clearly a focus on population health. In terms of quality measurement, value-based purchasing is increasingly common. We need to have metrics to improve care. We offer incentives for providers to treat these high patients. These are clear things that we're doing already. But what we see in most cases is quality measures focused on a single condition. Is the diabetes very well being monitored, being taken care of, which is incredibly important. We don't want to take away from that particular activity. But what we recognize is that the person who has high needs is not just a series of 5 diseases. There's a whole series of issues of coordinating their care that in most of the times the quality metrics have not taken a very good job of taking a look at. So basically more emphasis on metrics that emphasize care coordination, how to best manage care for the person who has multiple chronic conditions, because we heard with respect to mental health and diabetes, it's much more complicated to deal with the person with mental health and diabetes than just mental health or just diabetes. And we don't have very good metrics to do those kinds of things. The whole issue of quality of life, the whole issue of independence. What we heard from Veronica this morning is how much her mother wanted to remain at home, wanted to remain independent. And yet, how many metrics do we have out there that take a look at, can that person remain independent or not? We think that the more needs to be done on that. And then the whole issue of overall health status kinds of measures, not just with the diabetes and whatever. And finally, the issue of data infrastructure. There's so many disparate information systems, and David and everybody has worked on trying to make them much better, and we totally applaud those kinds of things. But what we see there is really much better in the medical side and not much better in the social service side, and not much better in the integration of the medical and social service side in these information systems. So how can we start designing information systems that are much better to integrate the medical and the social service systems? basically the federal government, the state governments, the local governments should identify barriers that exist in this information flow if you wanted to find out about the whole person, not just their medical needs or some aspect of their social service needs, but the whole person. So we need much better information systems. Ashish has been working on, developing this methodology using Medicare claims data, which is great, but there's a whole series of things that he cannot look at, that no one can look at. We can play a little bit with some smaller data sets which integrate a lot of these things, but not very many. So a much larger federal government effort to collect data on a lot of people that have a lot of healthcare needs is something that really needs to be done. Screening for social and behavioral things, data to define populations and target on their characteristics, an ability to change the outcome. This is an important thing that, again, haven't been focused on, is changing the outcomes. Targeting should be aligned across payers, across social services. Let me just end with somebody who established the Johns Hopkins Hospital and Johns Hopkins Medical School. He was one of the 4 people, and I think he had the idea 120 years ago, and it's essentially the idea that I think summarizes what I say. It's much more important to know what sort of patient has a disease than what sort of disease a patient has. And this is essentially what this group and the policy recommendations, if you have to remember one thing, it's what somebody said 120 years ago. Thank you.